And the last genus of gram-positive bacilli-shaped bacteria that don't make endospores is the mycobacterium. Again, they are gram-positive, but because of that mycolic acid, that lipid they have in their cell wall, they don't gram stain well, so we do that acid-fast stain. So they would be the ones that would show up as pink if they're acid-fast positive. Unique characteristics about bacteria in this genus. It takes a lot of time to make mycolic acid in the cell wall, so they're very slow to grow. They can survive being eaten by other white blood cells, so they're intracellular. That makes a really great virulence factor, allows them to survive for much longer. They're showing resistance to a lot of antimicrobial drugs. They resist gram staining, they resist drying out, they resist a lot of disinfectants. They're really hard to kill. The most famous, most common mycobacterium bacteria that affects humans is the Mycobacterium tuberculosis. There are 3 mycobacterium that cause disease in humans, but this one is by far the most common. The cases in the United States are decreasing. However, there still are cases. It's not anything that has gone away. It does cause a pulmonary disease. It really likes to get into the respiratory tract and set up residence there. We pick it up when we breathe it in, and it goes through 3 kind of stages. Again, if left untreated, it goes through primary, secondary, or disseminated. So primary tuberculosis is we breathe in the bacteria. Our immune system does what it's supposed to. We've got macrophages that are there to eat the bacteria, kind of clean them up. But because this particular bacteria does not get broken down, it can survive in those white blood cells. And these macrophages, which are big eating cells, they don't break the bacteria down. More white blood cells become recruited to fight off more bacteria. All of those white blood cells get contaminated with bacteria that they're eating, and the white blood cells start to stick together. When you get enough white blood cells all sticking together, they form a mass called a tubercle. Eventually, that's primary tuberculosis. Eventually, those cells do start to die, and you've got all of these cells, these bacteria cells that are inside this tubercle, and if this tubercle, this kind of big grouping of white blood cells, ruptures, that bacteria can travel to other alveoli in the lungs or even get into the bloodstream. This is when we get into secondary or reactivated tuberculosis. As long as it's still staying in the lung area of the body, it's just secondary or reactivated. When it spreads beyond the respiratory system, we now call it disseminated tuberculosis. Diagnosing it, again, we can do an acid-fast smear. It's acid-fast positive, it would show up pink. We can culture it. We can grow the bacteria, but they take a long time. We can use genetic probes looking for the specific DNA. We can also use the tuberculin skin test and chest x-rays. So what they end up doing, because again, I'm guessing most of you that have had to have TB tests done, your reactions did not look like this. What they put underneath your skin is a purified protein from the actual bacteria itself. So it's not the bacteria, but a protein, just a purified protein that comes from that bacteria. And if you've ever had exposure to tuberculosis, whether it's an active infection, because it takes a long time to get rid of it, you would have antibodies that would react with that protein, and you would have this very bright, almost inflamed look. That would tell you whether you have antibodies. That doesn't always mean you have an active infection, but then they would then go and do a chest x-ray looking for tubercles in the chest. But this gives a good indication if you either have a current or at least a previous infection. Treatment, lots of antibiotics, usually used for months, 6 months, if not longer. Again, they're hard to kill. They're resistant to a lot of these drugs. Prevention, we do have a vaccine where TB is a little more prevalent, but it's not super common. It's not routinely given, but if you do get the vaccine, your body does react. It does what it's supposed to. It does make antibodies, which means after vaccinated, your TB test would look like this, because it would indicate that you have antibodies against the bacteria. Best prevention, though, since vaccines are not very commonly given, especially here in the United States, is wearing a mask so that you avoid inhaling those droplets from your patients. The second of the mycobacterium that causes human disease, much rarer though, is the Mycobacterium leprae, which causes leprosy. Unique part about it, it actually grows at a cooler than body temperature. So body temperature 37 degrees Celsius. This particular bacteria grows best at 30 degrees Celsius. So it likes the extremities, so your fingertips, the end of your nose, the top part of your ears. That's where it's going to grow best. The reason why I've got armadillos, we haven't actually been able to make any kind of media where we can grow this particular bacteria. However, this bacteria grows really well in armadillos whose body temperature is 30 degrees Celsius. So luckily for us, it's a pretty rare bacteria. We don't see very many cases, especially here in the United States. It's spread person to person, usually if there's some kind of break in the skin from nasal secretions into that open wound. And just like TB, it's treated lots of antibiotics and usually given for a very long time period. And then the last of our gram-positive bacteria, it's a Mycobacterium avium intracellular, also known as Mycobacterium avium complex. It's the most common mycobacterial infection in AIDS patients. So that's not to say it's the most common mycobacterial infection, that would be TB. But in AIDS patients, we see more cases of this than we would in TB in AIDS patients. It's picked up from ingesting contaminated foods of water. And this bacteria, again, it can live intracellular. So we can see all of this dark pink is the bacteria living inside of our white blood cells. And ultimately, it will start to kill any cell that it gets into. Right now, treatment is difficult. It's kind of trial and error with different antibiotics on which ones will work. But although it really likes to get in and infect the macrophages, it can get into any cell in the body and eventually leading to full organ failure and death. So that's where we end on death.